Yet a very, very important episode for our organization, Reality and You Foundation. Today, I'm honored to have with me Dr. Johnson, who is currently serving as the president of the Albert Ellis Institute, which is a cognitive behavioral and an REBT institute in New York. Doctor, I'm thankful to you that in these stressful times, you are here to address a very important topic of mental health among the healthcare workers. Dr. Johnson, may I request you to say a few words about your journey? I have trained personally under you, and it has been an experience of a lifetime.
Well, thank you. Thank you for that really gracious introduction. I'm really happy to be here to talk about what I think is a really, really important topic that we haven't given voice to enough. We're just saying, well, push forward, and that's not always enough to just push forward. I actually did my undergraduate work in chemistry and psychology, and with more of a focus on chemistry, but then became interested in logic, and so ended up doing a doctorate in philosophy and the philosophy of mind. And so of course that gravitated me more toward psychology. So I did end up getting a master's in marriage and family therapy before getting a doctorate in psychotherapy. I wrote to the Albert Ellis once and just said, I was trained in a different model, but I'm really interested in your model. And I can't repeat his exact words because he spoke very colorfully. And he brought me to his office and he interviewed me. And so I stayed on for a number of years as a fellow. And then I became a proof supervisor, was on the staff, and and eventually served on the board of trustees. And now I am the president of the Albert Ellis Institute, which means that when I do workshops, they don't have to pay me anymore. So this is a very good honor. But my interest in the topic of trauma, especially trauma, comes out of my own personal experience. As when I was a child, I was on my way to my great-grandmother's funeral and I was hit by a car and suffered severely for a number of years. And that was before the DSM had the diagnosis of post-traumatic stress disorder. So it wasn't until I was in grad school and I was studying post-traumatic stress disorder, and I went, that's me, that is me, those symptoms. So it's been a life journey since then to specialize in that and look at what we can do to get better treatment for individuals who are under an inordinate amount of stress. And we know during COVID, so many individuals are experiencing so much stress and even may qualify for the diagnosis of post-traumatic stress disorder. So I'm really happy to be here, and I will try to speak a little slower when we're doing this. Okay.
So I just want to add in that Dr. Steve has written numerous books and articles, and he has trained a lot of counselors in REBT and CBT. And I can say this, that, India has now awakened to this new therapy and we are taking it forward. So thank you so much for that. Doctor, I'm just going to jump into the questions.
Please.
We are in the peak of our second wave. It's been extremely traumatic for us. We do not have the vaccines. It's an horrible, terrible experience. I know I'm awfulizing here, but it's extremely disappointing for the healthcare workers.
Yeah, and I think it is really, really bad. And let's not mince words. And I know people might say, it's not awful, and go off into that philosophical discussion, which is an utter waste of time, because what people are going through is suffering and experiencing trauma, and we need to respond to that at a human level, because we all share that, as Albert Ellis always clarified, and do what we can. The good news, I think, for many of us is this is not the first adversity to ever hit the world. We have experienced adversities as humans, and we have come out on the other side. And we've learned from them. And I think that learning can help us in this one. I mean, if we look at 9/11, we've looked at even way before that, when AIDS hit, and we didn't know what, in the early 80s, we didn't know what it was, and people were dying and suffering and worried about how they were catching it. Sounds a lot like COVID, maybe not at that pandemic level that we see right now, but we did learn from those, and that we can put that into practice, which is, I think, very good news.
So my first question from here is, how does one as a doctor prevent the burnout? Because there's been long working hours, shift onto shift. There's been a lot of guilt of saving patients to your utmost capacity. So can you suggest something for burnout?
I think burnout is, always there. We see it in treatment of other individuals. For example, the burnout rate among psychologists who are treating young women who have been sex trafficked, and that burnout rate with those psychologists is huge. Anytime we work with fellow humans who have been traumatized, there is that potential for burnout, or someone who doesn't have good boundaries, or a wife like mine that tells me stop working. Okay, then there's that possibility. But I think we need to look at burnout as composed of a lot of different factors and what we can do with that. There are some cognitive contributions to burnout, so that the way that we think about particular events and situations can contribute to that. There are predisposing factors from our life that would contribute to that. Some of those factors we can't do a whole lot about, but there are many of those factors that we do have some control over, and we can prepare for those. There are obvious things that our grandmothers taught us: get good rest, eat well, don't eat junk food, stay in relationship with people, don't isolate. If there are people who are being terribly negative around you, it might be nice to take a slight vacation from them, so that we are not surrounded by that. But really, we need to create a plan of self-care. And one thing that should go in that self-care, which I'm not great with, is actually to do some exercise. And people go, oh, that sounds trivial during this, but we owe it to ourselves to work at many different fronts in our lives to try to fortify ourselves so that we don't end up burned out. We can go into more detail about each of those factors as we go through this discussion about those cognitive contributions and other factors.
So, it's been 16 months since our healthcare workers have been going into hospitals with their PPE kits. Having taken the 2 doses of vaccination, there are still high chances that they will get COVID. They could get COVID. So when you're looking at anxiety and depression, doctor, how does one deal with that on a daily basis?
I think there's several things, and one that is helpful for people at an initial level is to get some psychoeducation about what really contributes to anxiety, what contributes to depression. Education is not enough. We have to put the education into practice. But several things that we do, and in REBT, which is the model that I use, rational emotive behavioral therapy, along with other models, primarily REBT, we know from a conceptualization of anxiety and depression what creates those kinds of dysfunctional emotions. When I say dysfunctional emotion, I do not mean any judgment toward anybody who's experiencing them. They're quite normal, and they're quite normal during these conditions. They're just not helpful. And there are practical things and steps and decisions that we need to make, and anxiety and depression can get in the way and sabotage us there. So it's in our best interest to get a grip on that. But one thing that we know is that while the situation is quite relevant, I mean, not having enough medication, not having enough vaccine, seeing individuals suffer and die in front of those set the stage for this. But there may not be the direct cause of that, because there will be some people who are in those situations who are just devastated, can't function, and there are others that do better. And we know a little bit of what contributes to that. One of the things would be unhelpful beliefs,
Right.
right? And the other one would be our inference about that. And this one is really important because the inference for anxiety is that there is a threat. There is a threat to us, and there is. COVID is a perfect
Yes.
example of that threat. A threat both to our life and to our comfort and to the life that we lived and that we enjoyed. And many of that, and that's been under attack for quite a long time. So knowing that inference that we perceive a threat in our environment, okay, so acknowledge that it's a threat. But then
Okay.
watch the beliefs that you form about it. Like, I shouldn't be going through this threat. Well, yes, you should. Why? You are, right? Unfortunately, the COVID is not a respecter of persons, the COVID
Right.
virus. And it just willy-nilly will grab whoever may be predisposed toward it, right? And all they're looking for is a host, and we are a host. And so it should be that way because that's the nature of an efficient virus such as COVID. Yeah, so thinking that it shouldn't happen and spending a lot of time with that is not going to help. Awfulizing, I think, is another one, saying this is terrible, horrible, and awful. And you know what? It is. Let's not pretend that this is not terrible, horrible, and awful. Now, I'm going to get REBT people yelling at me for that, but they need to go back and read the model, because what we know is it is not saying that this is awful and realizing that it is awful that is a problem. It is how much time are we spending awfulizing about it. If we spend our evenings and our free time just going over and over in our mind, this is terrible, this is horrible, this is awful, like, then we are not going to be playing in our A game. So it is the ongoing process of awfulizing that it is a problem, not declaring that this is awful. In addition to that is kind of frustration intolerance, and all of us are having frustration intolerance
Yeah.
here. These are not abnormal, they're just not helpful, right? And that would be like, oh, I can't stand this, this is too much, etc. Well, yeah, a lot of times we'll think that, but again, if we are spending an inordinate amount of time doing that, that's going to chip away at our effectiveness in life and sabotage us in reaching important goals that we need to achieve to help ourselves and others right now. And then the other one that we see, and then I will move on, is is global negative rating here. And what I am seeing is global negative rating about ourselves, that we are inadequate to handle this,
Right.
or global negative rating of life, that life is meaningless and purposeless and just a veil of tears, which is not true. There are parts of life that are really challenging, but once we engage in the global negative rating, we ignore really some noble acts of valor of among our colleagues and family members and all of that, that would be really helpful for us to take notice of.
So, doctor, like you said, a lot of healthcare workers find it very difficult to sleep. So the unhelpful ideas sort of dawn on them while they go to bed after a hectic day of work,
Right.
probably saving some lives and some not. So how does one sort of challenge and dispute those thoughts that overwhelm your sleep?
Yeah, and I think what we see there often is a two-step process that's not helpful. Of course, we may have some thoughts, we're processing the day, etc. And what we do with anxiety sometimes is we know people are going to do it. And so telling them don't do that is not really helpful. That's like telling a child not to eat the cookie that we put on the table in front of them. They're going to do it, right?
Right.
And we're all that way. But if we can put it, sometimes what we do is say, let's time it. Let's give ourselves 15, 30 minutes to just spend just looking over that. And at the end of that time, go, okay, I've done that. And then I'm going to do what I can to cease doing that. That's just one part that may not take care of the problem. But the other thing is, let's say I have some of those racing thoughts and got all of those, I've got a rush hour of negative thinking in my head. Then we disturb ourselves about the fact that we're not sleeping. So
Right.
the thoughts, unhelpful thoughts, cause us not to sleep, the distress, and then we disturb ourselves about our sleeplessness and we make it even worse. And so I think if we say, look, maybe I'm not going to get the best sleep in the world tonight. It's not awful. It's I'll catch up on that sleep somewhere else, but not be real negative about some of the sleeplessness. That's going to be normal right now.
Okay. And in terms of post-traumatic stress with healthcare workers, have you seen the same trend all over the world, especially in the United States, since most of it is coming out of the COVID pandemic?
Right.
So are we seeing similar results all over?
I can't pretend to know what's going on in India and Italy and Brazil and other places. Well aware of what's gone on where I am in New York City and in places like that, and the level of stress is huge. And and while the U.S. is doing better, we still have a large number of cases of COVID every day. We can't give up our masks yet, despite what our young people think, right? Um, so under a lot of stress, such that we have had healthcare workers develop PTSD and end up taking their lives as a result of this.
Right.
So this is something to take very, very seriously. Yeah, it's a huge problem.
And can you then go on and express some of the symptoms and the way one can sort of self-diagnose PTSD? So we have healthcare workers they have some background of what a post-traumatic stress can look like, but most of them tend to be in denial.
Yes. And yeah, if you go to one place where I would recommend it, and excuse me, an individual can look at to get real quick information about PTSD is just go to the website of the American Psychological Association, Division 12. And if you go to that website and you pull up PTSD, it will give you all the symptoms and it will give you evidence-based treatments for dealing with it. They're a little bit behind on the evidence-based treatments, but they do have a good number. But the categories of symptoms, are pretty clear. One is that the individual has to have experienced a traumatic event where there is the threat of life to themselves, or they were witnesses to the threat of life. So it doesn't have to be death, but just the threat of that. Some individuals, like police officers or healthcare workers or whatever, if they're watching videos or et cetera about that over and over as part of their occupation, watching those can contribute to it. For a normal individual who's not doing that and they're just watching a movie, no, that is not going to cause PTSD, but those individuals who are constantly watching that. The other thing then is that the stress has to negatively impact their lives in terms of the discomfort that they experience, but also in sabotaging them in reaching life goals. And those could be personal goals that you have just for you. Those could be interpersonal goals with your loved ones and friends and colleagues. They could be occupational goals. Maybe your performance as a professional goes down as a result of that. Educational goals, spiritual goals. If it is interfering with any of those domains in life, yeah, then there need to be intrusion symptoms, right? Those intrusion symptoms can be, flashbacks, to cases that they can't get out of their head,
Right.
those kinds of things. Hyper arousal, right? Like panic attacks, all those physiological symptoms that we see when the sympathetic nervous system gets activated, right? And cortisol begins to pump into our body. Nightmares, difficult, bad dreams, etc. It has to have, and these symptoms have to have lasted at least 1 month. It's not like there's a magic cutoff time, but we need something in the DSM. If you're having these symptoms and it's only been 29 days, then let's just say you have it, okay, and move forward. We have a different diagnosis, but it's all the same. Those are words. And then those symptoms cannot be due to a medical condition or a substance use disorder. So if you have those kinds of symptoms, even whether, technically you don't have PTSD or you do have PTSD, get help and begin to do something to address those symptoms.
And so, how does one maintain this balance between self preservation and then performing your duties, what you've given oath to, and that is saving lives?
Yeah. Well, I think the balance comes in a couple of areas, right? There's the balance of the way that we think. And so if we think in particular ways, then we are unbalanced. Whereas if we think in more helpful ways, we have a more emotional balance. And then it's also in the way that we act. So those unhelpful beliefs that I talked about, one of the things that we do there is what we call it cognitive restructuring. It's not, I mean, it's just, in psychology, we have to have our words so that we look like professionals, right? And all that means is we identify that our thinking is not helpful right now. We challenge that thinking and we convince ourselves that it's not helpful, right? Thinking like, oh, I'm justified in thinking that that's not helpful. We're just fooling ourselves when we think that. But then it's not enough to challenge it, but then let's replace that with more helpful beliefs. Instead of, I shouldn't be going through this, go, I wish I weren't going through this. No, I wouldn't wish this on my enemy, right? But I am going through this and there are things that I can do, okay? So we change that thinking. And the other thing will be in our actions, the self-care actions. You can take time to eat. That is important, right? We need to set aside some time for sleep. There will always be those patients there, but you are not Superwoman, you are not Superman, and it's not helpful for you to put that demand upon yourself. You do what you can, and you have a boundary and go, this is for sleep, this is for eating, this is for exercise. And people go, but I don't have time. And I'm like, well, you do, because we're not talking about hours on end. In a day, you may find 5 minutes where you can rest a little, or 10 minutes, and just build that into your schedule rather than thinking, oh, I have to have 6 uninterrupted hours. We wish that you had that, right? But sometimes we don't get that. And don't be an all or nothing person. Albert Ellis called it the Swiss cheese method. Get a little here, get a little there, get a little there. And aggregately, then you are getting more rest than you think. In fact, when we do studies and people say, I didn't get any sleep at all, and we've strapped them up to an EEG, we find out, yes, they did. They had some minutes here and some minutes there. It may not have been a restful sleep, maximally restful, but they are getting it. So don't globalize that you don't have the time. Do what you can and make that a priority, because if you don't, you are going to kind of sabotage yourself and contribute to your own distress.
And a very big part of what we are going through right now is, making decisions. So you are aware of it. The entire world is aware of it. We've had a shortage of oxygen, and to take the right call. So a lot of doctors sort of blame themselves, feel a lot of guilt. How does one cope through that?
Yeah. Again, that guilt will go, and again, guilt is normal. It's natural. You are not abnormal if you experience guilt. It's not helpful though. Take it from someone who, I specialize in guilt. That is my go-to emotion for everything. The sun's shining, I feel guilty, right? And so, but we do know some things about guilt. And one is that it usually comes from at least 2 kinds of beliefs that are really not helpful. One is that we put a demand upon ourselves, right? That we should or should not have done something. We should have done more, etc.
Right.
And we need to change that should too. I wish I had the time to have done more, but I don't, because I need to live a more balanced life so that I don't destroy myself. And because if I destroy myself, then all of the people I could have helped won't be helped. So I think it's a moral obligation to give up your should and be a little kinder to yourself. And I'm going to say a little bit more about that one in a minute, but I think the other one is to globally and negatively rate the self. If you don't do that, then you won't feel guilt. And And my recommendation, instead of rating the self, which is never helpful, absolutely never helpful, is it's a logical mistake when we do that. And I can think of a graphic, if you just take a piece of paper and you draw a circle on it and you write the word self inside that circle, that's you. That represents you, yourself. Don't evaluate that self. Don't rate that self. Just let that self sit there, okay? But move your body. And then the other is a list of the roles that you have. And one of your roles is a healthcare worker, right? Another one of your roles will be a parent. Another would be a friend. So whatever those roles are, and write those roles and realize and jot down what's your goal within that role, okay? And then evaluate your performance that day or whatever based upon what you did to help you reach that goal. And you may have done fairly well, you may have not done not so great, and just evaluate your performance. Don't rate the self. Leave the self alone, just rate the performance. Now here's the problem. There are certain roles that are really important to you more than other roles. And if you are a healthcare worker, that role you evaluate very, very strongly, right?
Yeah.
And so that means that we have to be more careful with our performance in that role than in other roles that are not as important to us, because we're more likely to globally rate the self based on our performance within that role. The problem is then you sabotage your performance in the role, right? So try to keep those separate. Be kind, don't evaluate the self, just rate your performance. Maybe even just have discussions around with that with other people and get connected with other people. What are things that they're doing to try to help them reach their goals when there's not enough equipment, when there's not enough people to go around to help. Okay.
And I think one thing that I want to point out is, like I said, sometimes when you have a huge load of patients in the ICU, like I said, decision making may be flawed. There may be a bias. There may be a cognitive failure there. How does one sort of accept that? I think that's accepting it and forgiving yourself, because you are out there to save the life. I mean,
right.
You're not out. Yeah. So that's a huge discomfort.
Again, that one goes back that if you're starting to feel guilty, use that feeling as a signal to yourself that you're not thinking properly. Okay. So as soon as you experience that guilt, go, uh-oh, what demand am I placing on myself that's not helpful right here, right now? Okay. And say, I'm just going to change that. Man, I wish I could do more, but I wish I were like the perfect doctor right now. But you know what? I'm overworked, I'm burdened, and I'm doing the best that I can. Okay. And actually doing pretty, and when we look at it, everybody's doing pretty darn good given what the resources are, right? So instead of putting yourself down, again, rate your performance, but not the self. Because here's what happens, is, and actually two factors, those thoughts will, if you embrace those, are going to cause sympathetic nervous system activation, and the cortisol begins to pump, and cortisol will not help your judgment be good, okay? And so that doesn't help. The other thing is globally perceiving a threat in front of you, okay? There is a threat, but to think that every second there's a threat in front of you is not helpful, right? Break this down into, there is threat, but the part of that threat I can do something about, and part of that threat I cannot do something about. Don't globalize that. Take that, and so that will help that, because as soon as you see this as a global, overwhelming threat, predominant threat, your body is going to kick in to sympathetic activation, and it's going to course cortisol through your body. And over the long haul, that's going to cause deleterious effects. So one of the things that we want to do that will help to offset that cortisol is to raise oxytocin levels. Well, there are some things that you can do to raise oxytocin levels. One is connect with other people. So take time in ICU or wherever you are, take a minute, connect with other people. After when you're resting, around some people, connect with, not with just COVID related stories, but how, check in how they're doing, how their family's doing. But that connection is deeply, deeply important. Even if you're using that connection to just complain about COVID, right? Of that connection will raise the cortisol levels. It would be really helpful for you. I mean,
And we've had, yeah. And we've had some cases of aggression, so when you lose a family member, of course, you sort of, in this situation today, blame the doctor that he could have acted much faster and taken the right call. So how does a doctor sort of deal with the aggression of the caretakers of the patient?
One, to expect it. I remember one of my supervisors, when I was a young therapist, I had a court-ordered case and they were throwing things against the wall and screaming and shouting. And I said, I can't handle these people anymore. I just can't handle it. And he said, Steve, why are they coming to see you? And I said, well, they got in trouble because they're disturbed. And he says, and how is a disturbed person supposed to act? Disturbed. So he said,
right,
your demand is that a disturbed individual, someone who's really upset about the loss of someone, should not act the way they do. They will act the way that they do, right? And the thing to do is not to personalize that, no matter what they're saying. They're distraught and they're not in their most rational state there, right? So expect it, but don't evaluate yourself based upon that. That's not easy. That's not easy to do, though.
right. And when you were saying don't personalize it, do we have any self statements that we can use here to sort of disconnect from this ground reality?
Well, one is to accept the reality and not think that they should be that they should just want to run up and hug the doctor and thank them for their selfless service to humanity. No,
Right.
they just lost a loved one, right? They're not going to do that. So I think accept the reality and not think that the reality has to be any different than it is, but also say, wait a minute, am I feeling guilty? Or am I feeling angry at that person for doing that? I'm feeling angry if I go, they shouldn't be saying this to me. Yes, they should. Why? They are. They're disturbed. Of course they are. So if we give up our demands about how they should act, and we don't take it personally and say, oh yeah, they're right. I am useless. I've done nothing but make mistakes. Okay, let's not go there. Realize that, yeah, maybe I do, make some mistakes, but the overall intent and the overall actions are actually quite helpful.
And the whole reality has sort of made a lot of doctors feel helpless.
Yeah.
Uh, maybe even, what is the point of studying so much, getting
Right.
these degrees, haven't worked in the field for 20 years when we cannot save patients in a pandemic? How does one sort of deal with those thoughts?
I'm glad you said that thought, because a lot of people think that when they feel hopeless, that's an emotion, and that's not an emotion, it's a thought. And one thing to ask yourself is, when I think that I am helpless and hopeless, is this helping me right now? Right now, when I think that I'm helpless and hopeless, does that help improve my care of myself and of my patients? And the answer is going to be a resounding no. So probably not the best thing to engage in. Again, quite normal to do that. The other thing that we do know from the work of Robert Emmons is really important here. And sometimes when we are dealing with a threat such as we are now, we kind of lose sight of what our long-range goals were and our values. And,
Right.
and one of the things that those healthcare workers, and I include the mental health professionals in there too, is what were the values that you really embrace that had you want to go into this field, that you have kind of lost sight of now in the face of, maybe errors that you make or the losses that you experience? You will always experience losses. They're more concentrated now, right? And so you've declared that it's too many. Well, then that thought's not helpful. But get back to those transcendental values that you have. I want to reduce suffering. And so when you look at your performance within your role, are there cases where you reduce suffering? If you did, you are moving toward your goal. So don't lose sight of those long range goals, but also have some short range goals in the middle of this. And those short range, because if you just have long range goals, sometimes it takes a while for you to see those results on the long range goals.
Yes.
But the short term goals, we need those. And those need to be things like eat well, exercise, talk to friends, and kind of put pleasure in your life. The other one is, the tendency is when we feel like we've lost sight of our goals is to feel all alone, right?
Right.
And so we need to stay connected, because when we are alone, I mean, it's not being alone that causes the problem, it's loneliness. And the difference between being alone and lonely is what you think about being alone, right? And so we do have some control over that. You are not helpless. And that's another thing to remind yourself. There are some things that you're helpless over, COVID, how long COVID has decided to stay with us, how many variants are going to come out. We're a little bit helpless there. We've got to do what we can to try to, get herd immunity, but we're a long ways away from that in most cases in the world. But there are some things that we have control over. And one of the things that we have control over is our self-care and the way that we're thinking about things. So do some things about the things that you can control and realize you are not helpless.
And Doctor, I've read a lot of stuff on compassion fatigue with the healthcare, and primarily I think this was in the flood situations and other natural calamities. So in terms of healthcare, we are experiencing a lot of compassion fatigue, I feel today. And how does one sort of deal with that? Can you tell us what is compassion fatigue in the first place?
Yeah, I mean, you're carrying, and I have no more left to care for, right?
Okay.
And so, look, I think the problem is that we think of compassion as this big thing, and we either have it or we don't have it. Like suddenly, compassion flies out the window. That is not the reality. What compassion is about is, and even in the good times, there are times when I am compassionate about things, and there are times when I'm not, right?
Right.
And right now is that there's so much we're being hit with is then we become unreasonable about how much compassion that we have. And if it's not what we think that we should have, then we think, oh, there's nothing else left to give. Well, there is compassion toward yourself, right? And you can forgive yourself. You don't have to embrace the global negative rating of yourself and the big demands upon yourself, because compassion begins with yourself. Because if you can't be compassionate toward yourself, it's the same kind of thinking that engages in lacking compassion toward others. The other thing is, quit being demanding on yourself. Of course, there are times when you're not going to be compassionate and you're just doing your duty. That's called your job, right? And there are times when we do that. I mean, think of it. It's like analogous to a marriage. And we go, oh, I have to love my spouse all the time. And I'm like, grow up. There are times when I just don't want to look at her, right? Etc. Does that mean I don't love or I lack compassion? No, it doesn't mean that. It means that I'm not having that experience of it right now, but the disposition within me is still there. So I think if we think of this as something that's dispositional, that's not going away. It may not be exercised in the way that I normally do it, but the disposition is there. And by holding on to those values that brought us into the field, we can maintain those. Be good to yourself.
Right. And Dr. Steve, I want to bring in the topic of suicide here. We've seen articles floating around on doctors, dying of suicide currently. It's extremely sad to see that people who save lives are today giving up their lives. So any thoughts on that?
Yeah, and this is where I think this is why it's so valuable that we have our healthcare workers and others create a community of health and caring to the degree that we can. Because sometimes when an individual gets to the level of having suicidal ideation and in creating plans, right? And even practicing those plans, because often someone practices before they actually
Right.
commit the suicide, is and that's also good to remember. It's not like it's just all of a sudden, right? Sometimes
Right.
it is, usually not. The act itself can be kind of precipitous, but the thinking about it is usually not precipitous. So I think if we, those of us, if we are distressed, it is really, really important for us to stay in community, even as aggravating as people can be sometimes, right? Including family, but stay connected. The other one is, and then for all of us to kind of look out for ourselves to see whether others are exhibiting the signs of suicidality. And one of those that we frequently see is isolation. Here's something that is really important in the research. When we
Right.
look the research into the default mode network, that system within the brain that really is important for autobiographical memory and the sense of self. That when we are depressed, and most individuals who take their lives, not all, are suffering from depression, then the story that we have in our head is more important and focused on more than the story of what's going on outside of our head, right?
Right.
So that the depressed person is living in their head and that story, and they're ruminating on it. They feel trapped. They feel that they're helpless and they're hopeless because they're not in touch with the world outside. So what do we know that we do? One of the best things that we do for depression is not so much doing the cognitive part, but the behavioral part. Get them out into the world and acting in the world with some pleasurable things. And those are simple things that we can do. Now, this is in preparation to try to fend off getting to the point of that, but things like, take a walk and use your senses and kind of enjoy the environment around you. Otherwise, we're too caught up in that autobiographical memory and that story of the self that is a failure,
Okay.
hopeless and helpless. And we need to get involved in task positive activities that are about increasing pleasure and connection with others.
And as a teammate, doctors work in teams. As a teammate, like I said, most doctors could be in denial, hiding and suppressing their thoughts and emotions.
Right.
What are some of the basic signs? Like you said, isolation could be one, but in a team, in a hospital setup, what are some of the signs you can see that somebody is not coping well?
One is, and some of these are physical, so it may be a little confusing sometimes.
Right.
Lack of energy, not communicating very, very well. When they do communicate, it's filled with kind of dark statements. Oh, what's the use? There's no purpose. Why am I investing? Why is the government not helping us to do our job? All of those kinds of things. Those are normal thoughts. But if we see a bunch of these symptoms together, the negative thinking, the social isolation, lack of energy, ruminating just on the same things over and over again that they're repeating, or, if people start, if they're doing that and then they suddenly become calm, become
Mm.
suspicious, okay, because they may have made some decision to kill themselves. Because often when the person is suicidal, they're going through a period of ambivalence about
Right.
doing this because it goes against our natural intuition and natural urges, right, to kill ourselves. And so there's that agitation. And so sometimes when they have some resolution about that, they get really calm. So on my clients who have PTSD, who suddenly become calm, I am on them like a pit bull, finding out what is really going on inside them. Yeah.
Thank you so much for that. So, Doctor, I can't end but talk about grief. So a lot of doctors have brought COVID home, and it's been a painful experience. They may have lost their spouse, their parents, their kids are suffering. So how does one cope with your own grief and then go back to work? And I want to point out here that grieving is a very spiritual experience in India.
Ah,
No matter what religion you belong to, we have a grieving ceremony, and COVID has taken that away from us. So it's been extremely difficult because we did have a place where we used to meet up while the grieving period was going on. And I think that connection was there, which is lost right now.
yeah, there's so much in that, and that's a whole talk in itself, to be quite honest. Grief, first, we want to discern whether it is indeed grief or whether it has become a complicated form of grief or whether they're actually depressed. And some of the signs of that, for example, might be with grief, there can be guilt, as
Right,
well as with depression, there can be guilt, but the guilt is a little different. With the guilt of depression, it's global guilt about everything. With the guilt in grief usually is localized to the loss. It's focused
right,
on that particular loss. And so, and by the way, um, if there's an inference about depression, it is that the individual has experienced a loss. And a lot of that is going on with COVID. So it's not a surprise that we're seeing anxiety and depression, because the inference for anxiety is that there's a threat, COVID's a threat, and the inference for depression is I've experienced a loss. And of course you've experienced a loss. We've all experienced losses here, but the
right.
loss of a loved one is just one of the most shattering for people. And I think one of the things to do, and I find these work-driven professionals, we tend not to be the best at this sometimes,
Right.
because with grief, you need to lean into the grief, not avoid it. Okay.
Okay.
But grief feels bad, so we want to avoid it. It doesn't help. And here, take some advice from DBT and ACT, where just sit with the grief, give yourself some time to do that. I mean, not like 24/7, no, but you do need some time to grieve. The other thing is to put it in perspective, and this is going to take some time, is that the individual that you have lost, you are going to maintain a relationship with them. And I'm not saying that in a spooky horror film kind of way, but
Right.
you will have a relationship. My father died almost 15 years ago. I still have a relationship with him. The
Yes.
relationship is one of memory and of stories, and we need some time to tell those stories and memories. And I come from a faith tradition where we have rituals that are stretched
Right.
out for over a year that we do, that involve grief, etc., and engagement with life and work. And those are so valuable. But COVID disrupted our rituals. And
Right.
so this is the time to innovate and go, you know what was the spirit behind those rituals? What part of that can we do now that may not have all the elements of the form that existed within our culture, but there are elements of it. So for example, um, in my tradition, they have a thing with this called sitting Shiva, right? Where people come over to the house and
Yes.
you put black on things, etc. And well, we can't do all of that. But you can say, what was the point of this? The point was to give us time to remember the good
Right.
things that they did and to acknowledge the loss. That's huge. Give yourself time, not to ignore, but to acknowledge the loss, lean into the discomfort. Don't let it be 24/7, and connect with people. And if you can't do the ritual, do the best you can with ritual. We do this anyway. I mean, my wife's Christian, and we have Christmas for the kids. And but the rituals for Christmas change as the kids get older. And so we can
Yes.
do it. Why not do that with the other rituals that we have in life? They change under certain circumstances, and we do the best we can.
And doctor, so how does one sort of, because a lot of doctors have a death in the family and they need to go back to work. And like you said, they're not processing the grief. Probably they don't have time to process the grief. So how do they sort of balance their life right now?
Right.
Because I for sure know that, with our population, it's become extremely difficult because doctors need to be on their job.
Right. So, you know, in some traditions, there is this time when we don't engage in work or anything and we just devote it
Right.
to grief. We may not be able to do that. And so I think it is to realize that, okay, that may be the ideal, but let's, instead of and judging what we're doing against the ideal, look at it as it's good enough, right? If I can take 5 minutes, if I can take 10 minutes and remember some, like what I do with my father, some fond stories about my father who was quite funny, and just remember that and just be thankful for his presence in my life and his contribution to who I am and what I value, and lean into that loss, 10 minutes, 15 minutes. And also the thing to remember is, and if you have a day or a few moments where you forget that loss and you were happy for a moment, some people judge themselves. Oh my gosh,
Right.
let it go. That's a gift. You know what I mean? And your loved one would have been so happy that you were having some happiness in the middle of your, in the middle of your grief, because if they're a loved one, what they were all about, right, was your happiness.
Happiness,
Yeah.
right. But I think a lot of doctors and healthcare workers are finding it difficult to be vulnerable to themselves, like you said, compassionate. So they do not want their vulnerability to come out.
I don't know what they mean. Vulnerability is to show that to the patient.
To show, maybe to show it even to themselves, if they have moments where they can cry or feel sad about, they sort of want to shut down with a wall and feel all macho and go back into the whole role of being a doctor and a savior.
I think one of the things that they could begin to do is to realize that they are not their role, right? And so, and not get confused about that. In philosophy, we would call that the philosophy of composition. They're taking a part of the self and making it the whole self. Well, let's be at least logical on this part, okay? That that is a role, and it may be inappropriate in certain times in that role when we show that vulnerability. So that if you're with that patient and suddenly you can't attend to them because you're breaking down and crying, that might not be appropriate to them, right?
Right.
But um, unconditionally accepting yourself, right, means accepting that you have emotions, accepting that you're going through the grief, accepting that you are vulnerable. And the other thing is, reframe the vulnerability. The vulnerability comes from strength. You know what I mean? Um, not from being macho. This is very interesting. The research that came out of UCLA showed that women often do far better with trauma than men do, because they befriend and they pull in community and they share that stuff. Whereas the man, that's not real helpful. What they're doing is maintaining their cortisol levels at a high level, and so men die younger, right? So let's be healthier and allow ourselves to be vulnerable and connect with other people who are safe for us to share that vulnerability. Now, don't walk down the street and grab people and start sharing. That's bizarre. That's New Yorker, but don't do that. But with appropriate individuals. And so that's what makes all of this very difficult with COVID, is that it has isolated us, and it has made the self, it has made the other person a threat, right? And so we've got to move beyond seeing each other as threat only, but that the threat is there. Don't personalize that in that individual. Take steps so that we fend off the threat as best we can. But you know what? I know at the university, when I walk on campus, we may not hug each other, but we give these hugs where we're looking like we're hugging, or we're, instead of shaking hands, we'll go like this. But that is a show of connection, etc. So I think they need to permit themselves to show their strength, and that's vulnerability.
Doctor,
One thing on that
yep.
one is Lisa Najavitz, who developed Seeking Safety, which is a wonderful treatment for PTSD and co-occurring substance use disorder, has this um, uh, uh, how should I say it? All of these techniques, but when she's doing treating men sometimes versus women in Seeking Safety, some of the titles of the interventions, they change. So for example, instead of saying Seeking Safety, when they do it for men, they would say reclaiming power. Okay.
Right.
And so
Right.
sometimes if we think about changing the word around that, so that, because words have powers and
Yes.
have action associated with it. And so if an individual sees getting connected and sharing is a way to reclaim power, time for that field to start embracing that, Yeah.
Doctor, I'm going to end it with the last question on finding meaning, purpose, hope, and growth. How do the doctors go through the pandemic? We are talking about a third wave coming into India
Yeah.
in probably October, November, and it's going to be a long haul for us. So how does one just, maintain that emotional stability?
Well, we've talked about emotional stability, and one of the things to do is always to look at the negative symptoms that we have as cues that our thinking may be a little off whack, right? Or that our actions are not connected with our values. And so I think and again, I go back to Emmons' work, one of the things that Emmons found was meaning, purpose, and even happiness are tied not to the attainment of a goal, but to striving for that goal, even in the face of difficult situations, okay? And so when we look at our striving, but that striving cannot be striving just blanket and divorced from goals, because sometimes that is just like, what's the use? That is when we have those kinds of thoughts, when we've lost sight of what that transcendental value is that we're
Right.
striving for, right? And so is to look at our striving, not our attainment, but our striving to try to reach those values, share that in story with community, because those long range values are tied to meaning and purpose. However, if you only do that, we do know from research that individuals who do that and do that alone have a propensity toward depression, right? If you're focused only on those ultimate values, why would they have a propensity toward depression? Because they're also not looking at short-term attainment of short-term goals, which are often tied to what? Pleasure. So we need the long-range goals for meaning, purpose, value. We need the short-term goals for the experience of pleasure. That's a wonderful combination. So I think those of us in mental health, when we're working with healthcare workers, is try to get them in touch with the long range, but also the short-term goals.
Thank you so much, Dr. Steve. This has been an extremely enlightening session. It has been a learning journey for me today in order to help people who are coping through their loss, their grief, and their trauma. Any last thoughts, Doctor, from you?
Well, we are, India is becoming more and more and more on our radar screen in the United States. And there's been a groundswell of Americans when they hear this we need to do more. We need to make sure that, because right now we're at a point where we have vaccinations and people not getting them because we've reached that level, is don't hoard it, send it overseas where we can get some help. So we are thinking about you. We want our government to take action so that it's up. And I know personally, it was few months before COVID hit that I was in India, and I saw you in India, right?
Yeah,
And very much enjoyed that. So we are experiencing concern and at times anxiety and loss. And I think we want to stay connected. We want to hear what's going on, and we want to kind of share some things that you're doing that you are finding helpful, and we do the same. Okay?
Thank you so much for helping us. Thank you so much.
All the best.
Thanks.